We were asked to do a piece of work working together with some of our anaesthetic colleagues about patients that were taking exogenous steroids. And again, I'm not sure I'll be able to offer solutions, but I thought I'd try and give you a little bit of background in terms of some of the guidelines that have been developed and really highlight issues where I think we're really lacking evidence. And I think that perhaps is the main problem. You'll all be very familiar with this. Is the hypothalamo pituitary adrenal axis, centrally driven, lots of central triggers that ultimately regulate the release of corticotrophin releasing hormone. That then acts on the anterior pituitary, on the corticotroph cells of the anterior pituitary, to release ACTH, which then acts on the adrenal cortex. And to release cortisol. And then there's the negative feedback loops that you're very familiar with there. So you're all overly very familiar with the hypothalamo pituitary adrenal axis. We know that cortisol, fundamental hormone, essential for life, regulates many crucial actions, not just metabolic, but in terms of maintaining blood pressure, response to stress, all these sort of things. And what we also know, and again, the terminology gets a little bit confusing. I think it's important just to rehearse that. We have primary adrenal insufficiency, whereby that's a defect of the adrenal gland itself. You have secondary adrenal insufficiency, which is a defect of the pituitary, where we see it. And again, we spend a lot of our time in clinics looking at patients with pituitary disease. And then there's this concept of tertiary adrenal insufficiency, which by and large, certainly in the context of this talk, will be about iatrogenic adrenal insufficiency. That's exogenous steroids causing suppression at all the different levels of the hypothalamo pituitary adrenal axis, resulting in endogenous glucocorticoid deficiency. And the key test that we often use, again, I put it here, you'll probably be familiar with this, is the Shortson-Acton test. The reason for putting it here is because a lot of the data I'm going to present uses the Shortson-Acton test, which is not a perfect test, but it's the test that we currently use most commonly to assess whether there is integrity of the hypothalamo pituitary adrenal axis. And how does we implement that? Well, it's a baseline cortisol, 250 micrograms of synthetic ACTH, which we tend to give IV, and then a 30-minute cortisol. And clearly, if you have got a functioning adrenal gland that isn't shriveled, that isn't atrophic, then you would expect a response at 30 minutes. And again, different centers have different levels of cortisol, and we can discuss that if you wish. So that's the basics. That's how we assess it, and that's, broadly speaking, how it can go wrong. So this is a problem that I've become progressively more and more interested, partly from a research angle, but also within our clinics. I have to say that of all the clinics that I do, probably 2 or 3 patients a week I'm seeing that have got iatrogenic glucocorticoid excess, be it from rheumatology, be it from respiratory, but it's a real problem. And we know, this is data from the UK and the US, 2 to 3% of the population are prescribed glucocorticoids. Highest in the elderly, and again, most commonly for respiratory. There's a slightly hazy graph you can see here, but what you can see here, as age increases, you can see that the prevalence of for glucocorticoid use increases significantly, and it's across all the different the doses, but actually most commonly for medium dose and in the elderly, and it's perhaps the elderly that are more prone to the adverse consequences of that glucocorticoid excess. If you correct for underlying disease, the glucocorticoid itself is still associated with increased cardiovascular, cerebrovascular disease and heart failure. That's relatively historical data from probably 15, 20 years ago. This is more recent data from Denmark, actually, and it looks at both the prevalence of glucocorticoid use, but also the incidence of new users. So the top 2 graphs, A and B, here are the prevalence going back to 1999 over the last 15 years. And again, you can see that actually it's reasonably steady. And again, that's here up to between 3 and 4% actually within Denmark, but hasn't really changed dramatically over those 15 years or so. However, when you divide it by age, what you can see here is that actually in those patients above 80, that's in the dots up here, you can see that up to 10% of patients are using glucocorticoid, and there does appear to have been a little bit of an increase around about sort of early 2000s, such that now about 11% of the population of Denmark over the age of 80 are using steroids, and again that's also reflected in the incidence. So in the elderly, this is the bottom graph D here. You can see that actually there perhaps is a trend to more new users of glucocorticoid, 3 to 4% on average per 100 patient per person years. So this is a big problem. I see it in my clinics, and as Steve has said, and certainly talking with anaesthetic colleagues here and further afield, it's clearly a big problem for you guys in your speciality as well. One of the big things that we have to think about is, we get very endocrinologists. I think we're, as we'll see a little bit later, I think we're quite a risk-averse group of individuals, and we get very worried that we're going to miss adverse outcomes. But what we do know is that primary adrenal insufficiency, that's a primary defect of the adrenal gland, is associated with a mortality. And part of that will be adrenal crisis, whereby you don't get sufficient glucocorticoid at times of intercurrent illness or stress. And so, again, a variety of different studies. These are standardized mortality ratios with reasonable numbers of patients, not huge, but reasonable numbers, showing that really across the board, the standardized mortality ratio is significantly increased in both men and women in patients with primary adrenal insufficiency. What about secondary adrenal insufficiency? This is work done by Mark Sherlock, a colleague who I used to work with in Birmingham. So secondary adrenal insufficiency, that's a pituitary problem, ACTH deficiency. And again, what you can see here, this is your mortality relative risk here, and markers can be compared if you've got a normal ACTH or if you're deficient. And you can certainly see that those patients who are deficient in ACTH with secondary adrenal insufficiency have an increased standardized mortality ratio here, and that's not the case if you're TSH or if you're gonadotrophin deficient. And if you look at the panel here over on the right-hand side, Mark's divided this up by daily dose. And I think that's something that we'll come to in a minute. And you can see here that actually, that if you're on a higher daily dose of hydrocortisone, your standardized mortality ratio is a little bit higher, suggesting that over-replacement is also not such a good thing. And that's even broken down a bit further with a bit more granularity here, such that if you're on a hydrocortisone dose of greater than 30, physiological replacement dose around about 20 milligrams per 24 hours, you can see that your standardized mortality ratio is higher. So, clearly in the context of replacement, too much and too little is bad. And that is also reflected in this. This is the, I think probably today the only really meta-analysis that has actually tried to look at outcomes in prescribed glucocorticoids. So this was done by Paul Stewart and his team in Sheffield. In Leeds, and it used a CPRD, so primary care database, and it identified 70,000 patients who were prescribed oral glucocorticoids, and it stratified those to those who had either evidence of adrenal insufficiency or patients that had evidence of glucocorticoid excess. And if you really cut to the quick, if you look at the IRR, that's the incidence rate ratio of death effectively. And you can see that in the far right-hand panel here. Certainly those patients on glucocorticoids, when he compares with those not on glucocorticoids, have an increased mortality. And that's true whether you've either got excess, so that's with glucocorticoid-induced Cushing's here, 2.24, or with glucocorticoid-induced adrenal insufficiency, accepting that the numbers here are pretty small. So again, we know now evidence from primary care that too much and too little glucocorticoid, prescribed glucocorticoid, is associated with an adverse outcome. So again, a few years ago, we just began to drill down on the types of glucocorticoid and evidence of adrenal insufficiency. There was and again, I hope I'm not offending anyone here, but there used to be a trail of thought that said, well, if you're on an inhaled steroid, that doesn't cause adrenal insufficiency, it doesn't get into the circulation. I would like to think that everyone's now aware that that is actually complete rubbish. And again, some of the evidence of that, there's lots of evidence to suggest that that is absolutely true. But here's just some of the evidence that we generated a few years ago. And we took about 2,000 or 3,000 patients that had synactin tests, and we pulled out those ones that had glucocorticoid treatments. And there were some that were glucocorticoid naive, some that were on previous treatments, and some that were on current. And this is the percentage that were failing the short synactin test. So if you were currently on glucocorticoid, 30 to 40% of people were failing the short synactin test. Not a great surprise there. But when you drill that down by glucocorticoid route, yes, oral was the worst, but still a significant proportion on inhaled, topical, intranasal steroids were all failing the short synactin test. And again, I think there isn't a single route of administration that hasn't been in some study associated with adrenal insufficiency, including the joint injections, which are particularly potent at causing adrenal suppression. We drill down a little bit on fluticasone, again, commonly used potent inhaled glucocorticoid. And you can see here, once you're onto sort of, reasonably punchy doses, 250 micrograms a day, 50% of people are failing synactin test. And when you look at the data, actually, it maps out quite nicely. So with increasing fluticasone daily doses, your basal cortisol falls and your 30-minute cortisol falls. What about prednisolone, oral prednisolone? So again, we used to think that that if you're on 5 milligrams of prednisolone, that's a pretty safe dose. We don't need to worry about adrenal insufficiency. I'm not entirely sure that's the case. This is again data from Leeds, and you can see here this is patients on increasing doses of prednisolone, 5 to 7.5 and over 7.5. And even at 5, getting on for less than 5, 30% of people also are failing a short synactin test. When you're at 7.5, 70 or 75% are failing the short synactin test. This is all quite dirty data. There are lots of problems with it. It doesn't necessarily look at previous exposure. So, but I think it just highlights that if you've got a patient in front of you and they happen to be on a dose of inhaled or prednisolone at that time, then their risk of adrenal insufficiency is potentially significant. How can we try and rationalize it? We can't suggest for one moment that every patient needs to have a short synactin test. And again, this is a busy, complicated slide, and I'll try and summarize it, because what we were trying to do with this data was say, is there a simpler way whereby we can assess whether someone does or doesn't have adrenal insufficiency based on effectively just a morning cortisol? And so what we tried to do is take all our patients that were either on inhaled or oral glucocorticoids and set the specificity and sensitivity of our morning cortisol such that we didn't want to miss any one. So our 100% specificity here would be when we didn't miss anyone that subsequently went on to fail the synactin test. So we picked up everyone that was adrenally insufficient. And by and large, if you set your threshold for morning cortisol around about 340, then you picked up the vast majority of patients who had an intact hypothalamo-pituitary adrenal axis. Similarly, if you drop down to below 100, everyone failed the synactin test. So you can begin to rationalize a little bit. And again, this is now these sort of data, again, with lots of other studies. All the studies have really come around saying, by and large, if you have a morning cortisol of 300, 350, that is a very good indicator that you've got an intact hypothalamo-pituitary adrenal axis. And again, that's now been incorporated into recent guidelines that I'll talk to you about in a minute. So that's the sort of some of the background, some of the work that we were doing. But what about what happens under stress? And again, this is now moving into your realm rather than mine. And this is data from one of my colleagues, Viv in Birmingham, and she looked to assess the degree of hypercortisolemia that you get at times of stress and patients undergoing elective surgery. So again, if you look at the panel here on the left-hand side, you can see that your morning cortisol levels are around about 200-300 in patients, but quite a big spread. We know that it's very variable, and you're clearly aware it has a circadian rhythm. When we look at patients under, for example, combat stress, these were soldiers in the military unit within Birmingham, or under elective surgery, your levels of cortisol are 2 or 3 times higher. Interestingly, they go through the roof in sepsis, but in acute trauma, perhaps less impressive than you might have expected. And these are also reflected in changes in free cortisol level. Again, as you'll all be aware, what we measure in the vast majority of assays is total serum cortisol, of which 90-95% is bound to protein. So high levels of cortisol than you might in patients having elective surgery. And then the question is, okay, well, if you were considering supplementing or replacing steroids, how might you do that? And there are various ways that you can do that. And again, Vika and her team explored that, and looked at cortisol levels if you dose people orally every 6 hours. And you can see there are sort of peaks and troughs. The sort of the orange bars here are sort of where you might like to see the levels. So sometimes if you give it orally, above and below. It's not dissimilar if you give it intramuscularly, intravenously, similar patterns. But if you give a 24-hour continuous infusion, again, these are the same doses, you can see you get quite a nice sort of flat profile. So certainly an infusion gives you perhaps the smoothest the smoothest of profiles, as we'll come to towards the end of this talk in a few minutes' time. It'll be very clear what we don't have is outcome data, and that's absolutely what we need in terms of, do any of these supplementation regimens make a difference to outcome? But we'll come back to that. So it's all very well and good. I think endocrinologists often fall foul of just trying to get numbers looking good. And the hypothalamic pituitary adrenal axis is incredibly complicated because it's not just simply a question of, CRH, ACTH, cortisol, going to a tissue, doing some stuff, because there's a whole host of things that are sort of going on. And especially if people are either unwell, they're stressed, or they're having operations. So we know that there are central issues in terms of how your hypothalamus and your pituitary gland respond in terms of your ability to produce CRH or ACTH. There's relative ACTH resistance at the level of the adrenal gland if you're unwell. Your cortisol production as a consequence of cholesterol, that can impact if your liver metabolism is not quite as good as it would be. There are changes in the periphery, so that we know that there's alterations in the metabolism of cortisol. Again, one of the enzymes that we've been working on here, this 11-beta-HSD system. Your glucocorticoid receptor expression changes with illness. The transport cortisol binding globulin is and your free cortisol changes. So there are lots and lots of issues. It's not as simple as saying, well, we just need to replicate a specific level in the blood, because that doesn't tell us what's going on within the tissues. So that's the sort of the background of where we're at. And again, based on a case that went to the coroner, who sadly died, who was a patient on glucocorticoids and didn't get supplementation. We sat down with some of your anaesthetic colleagues and proposed, this is a group of anaesthetists and endocrinologists that we came together at the Royal College to say, well, okay, how can we try and prevent those sorts of issues happening again? And we freely admitted, as you'll know if you read the guidelines, that this is very much an evidence-free zone. And I think we all felt that we probably had to act in a safety-first way. And therefore, after significant and lengthy discussion across the table, we came up with the recommendations here that actually, that at times of major surgery, that we would recommend that people got if they had evidence of adrenal insufficiency, and here we stated it had been a prednisolone equivalent for 5 milligrams or greater for more than 4 weeks, and we'll come on to that a little bit in a moment. The patients would be given 100 milligrams at the induction of anaesthesia, and then 200 milligrams over 24 hours, which we were sort of slightly relaxed is that yes, you could use an infusion, but there were other alternatives, and that you could use 50 milligrams 6 hourly if an infusion wasn't deemed to be practicable. And again, similar sorts of things for other body surgery, things requiring general anaesthesia. Much more recently, in fact, just this year, the European Society of Endocrinology has published a guideline on the diagnosis and the treatment of glucocorticoid adrenal insufficiency. Again, I wasn't involved in drafting up these guidelines, but I think they're quite helpful. And again, you'll see if you dig into those guidelines how little evidence they are based upon, and you can see sort of here that they're based on sort of good clinical practice but no real evidence. And what do they recommend? Well, they recommend that with patients with glucocorticoid induced adrenal insufficiency, that they should receive stress dose coverage when they're exposed to stress. That I think is very clear. But at times of major stress, and they include that in terms of general or regional anaesthesia, that parenteral glucocorticoids should be used. They did go on a little bit then to say, well, okay, how can you identify who are the patients? Because this is part of the issue. Who are the patients who've got glucocorticoid adrenal insufficiency? So what they actually said was that we can't really test everyone, and that actually, provided people are clinically well, that may be sufficient, but we should have a degree of awareness in specific groups of patients. And it's those patients that have either, current or recent use of preparations who've got signs and symptoms of adrenal insufficiency. That may be, postural hypotension, that may be fatigue. So things that may alert you to adrenal insufficiency. If you're on lots of different types of glucocorticoid, high doses of inhaled, high doses of topical for a grade of the year, intra-articular glucocorticoids are particularly potent at causing adrenal suppression. and those who are on cytochrome P450 CYP3A4 inhibitors. And the CYP3A4 is critical for the metabolism of glucocorticoids, exogenous glucocorticoids, and therefore if you're on an inhibitor of CYP3A4, you have effectively the steroids that you've been given have a more potent action, they have a prolonged half-life, and therefore are more prone to give adrenal insufficiency. So those are the sort of guidelines. And again, we had tried to get some funding with Ben Gibbison to try and generate some evidence. And part of the initial thought processes but behind that was to try and do a survey, and many of you may well have been involved in this. But this was the perioperative replacement of exogenous steroids audit, which again you may well have been involved with, which was trying to assess, okay, we've written these guidelines which were published 3 or 4 years ago. How well are they being implemented? And I think the results were really interesting, perhaps alarming. And again, on the back of that, I was invited to write the editorial, which is where the title of this sort of talk came from. So this was nearly 60 trusts, 21,000 patients, of whom about 1.3% were taking steroids. And again, you can look at I've sort of highlighted some of the crucial. I'm just showing one table because many of you will have been aware of this. And so the analysis was divided into two: those who were on 5 milligram of prednisolone equivalents or higher, and those who were on less than 5 milligrams. And what you can see here is that if you look at the proportion of people that were compliant perioperatively with the guidance, probably only about 30%, about 50% for those people who were on less than 5. Post-operative, perhaps even less for the higher doses, 20%. And then if you look at the entire peri and post-operative compliance with the guidelines, only really about 9% were fully compliant with the guidelines for those over 5 milligrams, and about 50% for those less than 5 milligrams. Other issues that came out of this, I suppose, were sort of an awareness as well, actually, and that's a problem that isn't, just restricted to anaesthetists. Making people aware of guidelines is important. So, if people aren't aware of them, they're not going to read them. Once you make people aware of them, it's about reading them. And again, there are lots of reasons as to why people may not have been following guidance, and perhaps we'll be able to discuss some of those. So I'm just going to begin to wrap up there. That was sort of setting the scene. I don't have the answers because we really do lack a lot of evidence here. But I think we just need to be aware of the situations. We know that actually that adrenal insufficiency caused by exogenous steroids is associated with adverse outcome. That I think is very, 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 very clear. It's also very common, and we've already mentioned that the SST is not a perfect test, but even if you define it by the SST, then actually we can pick up a lot of adrenal insufficiency. Questions about how the best way to diagnose it, and I think there is consensus now that we can't do short-acting test, 9 cortisols in everyone on steroids. That's just too big a thing. So we have to look at those patients at risk, and it's those patients who are on lots of medication, longer duration, higher doses, concomitant medication that can exacerbate the potency of glucocorticoids. In our defence, the guidelines for the supplementation were based on a safety first approach, and we all admitted that there was a lack of evidence. And I'm sure that's something that may come up in the discussion after the talk. But here we do have a lack of evidence for either harm or benefit with or without supplementation. And again, we have tried in the past to secure funding to address that, and that's some work that we were doing with Ben down in Bristol, but sadly wasn't funded. I do wonder, and I've put their query hampered by guidelines, that now we've published these guidelines, is that actually going to make doing research a little bit more tricky? Because actually, if the guidelines say, well, we should be supplementing this, that, or the other, then how can we then go against those guidelines to do research? But I think there are ways around that. Then there are issues about the awareness and implementation of guidelines, and again, I've just sort of alluded to those. And absolutely, there's a need for more evidence, and we need to think about how we can carefully design studies and acquire data, really to see if supplementation with steroids to those patients at risk of adrenal insufficiency makes a difference to outcome. And that's the fundamental question, because if it doesn't make a difference to the outcome, then we probably don't need to do it. But at the moment, we don't have that evidence, and therefore we act on a safety first principle. So I'm going to stop there. I hope that was interesting and informative.